welcome to the Public Health PBRN virtual meeting for October. Um, we're celebrating the government being back in business. Great to see that this latest chapter finally over, although um, it means I got to get on a plane tonight to head to DC, but that's a price I'm willing to pay for a functional federal government again. And thanks to everybody for being with us. And we've got an action-packed agenda as usual this month. Lots of great things happening in the public health PBRN program these days. We'll start it off as we always do with our research in progress segment. This month brought to us by our colleagues in the New Jersey PBRN. One of our more recent networks, but one of our more active networks these days. Some great work happening. In particular, New Jersey's involvement in our multi-network MPROVE study has been very, very important. Our colleagues in New Jersey have really played pivotal roles in helping us shape the direction of this study and helping us think through some important issues around measurement and how to deal with the complexities of different public health settings and local public health jurisdictions, and the many different flavors they come in, the many different pathways through which public health services are delivered in the great state of New Jersey. And so we're going to hear from our colleagues Natalie Polinko and Susan Gierman today. And so welcome, Natalie and Susan. Thanks so much for teeing this up for us today. And we will turn it over to you.
Thank you, Glenn. This is Natalie Polinko from the State Health Department in New Jersey, and my colleague Susan Gierman, who's been our project lead for the MPROVE study, and I are pleased to bring you an overview of some of the work that we've been doing and how we've tied it with the MPROVE study and the work that we've been doing with Glenn Mays and his great team. So let me begin by saying that when I first started at the State Health Department in 2005, one of my deliverables was to take a look at the data that local health departments are required by law to provide to the State Health Department. And to say that it was a bit of a dog's breakfast at that time would be a serious understatement. In 2006, I started working on a proposal of how can we improve the information that we gather from health departments. And it's taken this long for us to get this project off the ground and actually implemented, over 6 years. But I stuck with it because I feel it's really important, and I'll be talking about why I think it's important in just a moment. So today we're going to be focusing in on this work that we've undertaken here at the state to create this local health report. And then I'll give it over to Susan to tie it back to the MPROVE study and how we've been able to leverage the work of the LHR to inform the MPROVE study. So, all of you know that the pace of change around us is just incredible. And in the midst of all these profound economic pressures to cut, governmental public health has to meet the challenge of not only branding itself, but demonstrating why it deserves public support. And recently there was a really great article by Bill Gates in the Wall Street Journal, and he put it beautifully when he said he was struck by how important measurement is to improving the human condition. That is, if you set a clear goal and a clear measure, you can move the needle on the dial. And while it seems very basic, it's not easy, and I'm guessing that's probably why it doesn't happen all that often. But it is important to measure, and with the feedback that we received over the years in New Jersey and the pressures that we're under, we recognize that public health, in particular in New Jersey, governmental public health, needed to consistently and powerfully tell the story of its successes. So in 2010, I turned to our state university and our great partners at Rutgers University to help us revise that 2005 product that I had been given, the Local Health Evaluation Report, and to create a new data management system that would have high value but low burden for health departments, can be used to measure performance and eventually show impact on health outcomes, is consistent, valid, and reliable across all health departments, and consolidates the many, many state-required paper-based reports to the greatest extent possible. So those were our overarching objectives and guideposts, if you will. So now I'm going to tell you a little bit about the work of the past 3 years and how we got to what we now call the New Jersey Local Health Report. So when I first discussed this project with Rutgers University, I made one precondition very clear. The report, the new local health report, had to be developed by and for local health department staff. In other words, it had to be extremely relevant to what they were doing. They took this very seriously. We gathered data and input from New Jersey's 95 health departments in 5 different ways. We did direct interviews. We did a statewide survey. We pilot tested the some 369 metrics we originally started with, and we had a steering committee that assisted us in doing a final set of reviews. So that steering committee was all important because it was made up of our staff, academics from Rutgers and other places, and the public health practitioners. And they agreed that the report really needs to focus in on 3 primary areas. First, it must summarize the programs and services that health departments collectively deliver statewide. This is either direct services or through formal partnerships. Secondly, it should quantify the money and the people that are collectively deployed at health departments around the state. That information shows us whether public health resources are rising or falling each year, and by how much. And third, the report should measure outcomes of local health department work rather than simply counting activities. But because public health outcome data is notoriously difficult to quantify, the steering committee agreed to an important qualifying statement. The new local health report should quantify those items to the greatest extent practical. So the steering committee also agreed that there were 4 other qualifying elements in the work, that at least kind of as a common denominator, the services most commonly provided by health departments should be included in the report. And when we did that statewide survey, we discovered that at least 75% of departments provided 40 services. So we used that as our first ACOMS raiser, if you will. Secondly, health departments in New Jersey are required by law to provide certain services. So those are certainly a part of the local health report. Thirdly, we know that health departments get multiple ad hoc data requests, and we're guilty of this too. So we're hoping to replace that burdensome data requesting from us and also our colleagues at Environmental Protection so that it reduces the load on health departments. And finally, we did not want to include information that failed the cost-benefit test, and this was a subjective measure. In other words, the value of the information to local health departments and to us, the state health department, had to outweigh the time local health departments spend to gather and record it. So now I'm going to actually go into the report so that you can see a little bit of what it's going to look like. This thing that I'm going to show you is actually the paper-based report that we are using right now to help local health departments gather the information. It will not look like this when it goes online because that will be an online web-enabled relational database that won't look anything like the paper, but here we go. So to create the local health report, we actually started at the end. We asked the health departments, as I said at the beginning, what do you need? What are your goals and what are your needs? And the local health report is designed to reduce local health department reporting burden. So it replaces multiple uncoordinated reports that local health departments were completing for different state agencies. along the road, it was very interesting. We were able to work with those other state agencies or other programs in the Department of Health and help them clarify why they were asking for certain types of information and even streamline the reporting that they were requiring from health departments. So in the end, we were able to consolidate 10 paper-based reports that were submitted by local health departments by either fax, mail, sometimes email, sometimes carrier pigeon, into this single online data collection portal. And secondly, we were able to create the system such that once the health department enters certain administrative data, once they won't have to repeat it again, which saves a great deal of time. The local health report also gives the health departments the power to produce a localized report which is customizable. So they can choose whether to track the data at the municipal level and save the data for each town that they serve separately, or they can do it at the department level. So it could be for multiple towns across a county or multiple municipality jurisdiction, because we have lots of variations on the theme in New Jersey. And the best part is, and this is what we're hoping to see at the end of this work, is that health departments will be able to produce on demand pre-filled customizable reports for each of the towns they serve. And talk about making the invisible visible. This is really where we're going with this. We want health departments to be able to show value. We want them to be able to demonstrate the work that they're doing, and so on. So here are the actual elements that are in the local health report. There's two types of data. There's administrative information, budget, personnel, and so on. And then there's the program and service information, so things that you see there on the list: retail food safety, septic systems, tanning facilities, public health nursing, and a number of others. This provides us with the foundation for our ongoing efforts to standardize and streamline other existing and reporting and data management that's currently conducted via non-electronic means. So for example, health departments go out and do retail food inspections. Many of them continue to do this on a paper-based format. Some have actually moved to handheld pads that then download the data to their central system. We would like to create a uniform statewide system so that the daily retail food inspections are captured and then uploaded to the local health report on a real-time basis. So we have actually 10 phases of this project. This is just phase one. So connecting daily reporting or daily activities to an annual report is part of our phase 2 plan. So how is this actually going to work? As I said earlier, the new local health report will be an online data portal that will allow health departments to submit data. This will actually go live January 1st, 2014. But this Excel file that I'm going to walk you through really quickly is a paper-based version of the online system, which we sent to all the local health departments in the beginning of March of this year. We did an orientation, we did a rollout, and the intent is for health departments to use this paper-based system to capture the data so that they don't have to go back at the end of the year and recreate, dig through files, and go through a laborious process of recreating the data that they will then need to put online or enter online in January. So very quickly, some of the contents of the local health report itself: when you open up the file, this Excel file, the first thing you see is the welcome page, and the link in the center of the page actually jumps to the table of contents. So the second page is the table of contents, and the file has actually been formatted so that health departments can navigate using links, just like a website. You can jump from section to section using the tabs at the bottom of the Excel, and the tabs are correlated with the table of contents. You'll notice that some of the sections are actually not linked, specifically childhood-led and communicable disease. In New Jersey, we have separate systems that collect data real-time on childhood-led and on communicable disease activities. So those are not being included in the local health report simply because we don't want to duplicate information gathering. In some later phase, we hope to be able to have those disparate data systems, and our communicable disease and lead data systems are quite sophisticated, have them talk to the local health report and perhaps be able to import and export data. So when you go into a particular section, this is just an example of some of the reports that are contained in the local health report. I'm sorry that the print is a little small, but you can see at the top on-site wastewater disposal systems, food establishment safety, department contact and leadership information, and so on. And here's a blow-up of one of the reports. This happens to be on body art facilities. So the title is highlighted in yellow, and then there is a description below of how the data needs to be collected. Each individual question is numbered, and if someone wants to see a glossary definition for a question, all they had to do is hover over the question, and there's a pop-up that explains exactly what the terms mean. When I first started looking at our old system, one of the greatest challenges was was reliability and validity of the old instruments we had. We had no glossaries, so ensuring that people are answering the questions was absolutely essential. So if we have multiple choice questions, which we do in the local health report, there are drop downs even in the Excel file, so folks can select a response. And we were wanting the Excel file to be as positioning people to be thinking about the online system, so there will be a great deal of mirroring. But this is just the paper-based instrument now. And then finally, there are some variations in terms of what's required and what's not required. The highlighted areas signify the following. If a question is in dark gray, the state provides the data, so we're going to be pre-populating the local health report with certain data sets. If the question is light tan or gray, that particular question is optional. And then the questions with the white backgrounds are required data. So that's the data that the local health departments will be putting into the system. What we were also very keenly aware of was that there needed to be high value added for health department staff and CEOs that are putting information into a system. They needed to get something out of it. So we built in a customizable report, and this is what we hope they will be able to get out of the local health report after they've input their data. So one of the things we don't have in New Jersey is a good branding for public health, and I'm hoping that this will assist in the branding of public health in New Jersey. The local health report itself is intended to improve and radically simplify the reports that local health departments create. So this report on the tail end, on the output end, actually features branding, graphics. We hope that this will help communicate the value of public health with a clear and consistent voice. These report templates are standardized and customizable. On the standardized side, it incorporates layouts and formats that we adapted from reports that we've seen in New Jersey that we really liked, that we thought were effective. If the health department chooses, they can produce these reports instantly from the data that they enter. The local health report will also allow my Office of Local Public Health to create a timely summary of local health resources, capacities, activities, and so on in New Jersey on an annual basis. This is not unlike the NACCHO annual profile report. As that does for the nation, this New Jersey report, I hope, will provide a yearly snapshot of our collective resources, our services, and by extension, impact. So these reports will summarize statewide activities. They don't, however, compare individual departments against each other. So here's the inside of the customizable report. If they want to customize the report, the local health department can include things like personal stories of people that they have helped. Many departments want to connect faces and voices to the numbers of people that they help, and we know that that's really effective. They can add their proudest achievements and their highest value programs. They can write their own narrative to celebrate their successes. And they can also include numbers from their highest value programs. One department may choose to feature its stellar animal control unit, while another one may want to talk about failed septics repaired over the year. And I'll tell you, after Hurricane Sandy, failed septic systems was high on a lot of people's radars. So having the ability to customize those data sets or those data reports in this report for their key stakeholder consumers will be extremely important. So that's on the output side. Um, that's a very quick overview of how we got to the local health report, what health departments will be entering into it, and what we hope they will be able to gain from it. Now I'm going to turn the presentation over to my colleague, Susan Gurman, who will talk about the relationship of this work to our MPROVE study that we've been participating in over the past year and a half.
Okay, hi, I'm Susan Gurman. I'm just going to go over the MPROVE study, particularly for those PBRNs which may not be familiar with it, and I think there's a bunch of people on the call who are not, so hopefully this will be useful. The MPROVE study is, of course, organized through the Robert Wood Johnson Foundation-funded PBRN program, and we are one of 7 PBRNs participating in this descriptive study of geographic variation of public health service and activity delivery. The purpose of the MPROVE study is to quantify and characterize geographic variation, both within each PBRN and across the 7 participating PBRNs of a set of public health services and activities that are associated with population health rather than clinical services, for example. And the study results will be useful for identifying opportunities to improve public health delivery. So the 7 PBRNs participating in the study are Colorado, Florida, Minnesota, New Jersey, North Carolina, Tennessee, and Washington. And the practice settings consist of local government health agencies within these PBRNs, and there's an approximate total of 349 local health agencies across the 7 PBRNs. And this is a very rough timeline of study activity. A good amount of time was spent on just measure selection. That was that took up 2012 pretty much. And then in January, we started collecting data. And at this point, I am probably about to start pooling the data across all the networks. And I think each PBRN is varied on their schedule with this, but we're just starting our data analysis, and then dissemination, and then planning for future and follow-up studies using this data going forward. So the measures for the MPROVE study needed to be in 3 domains of public health service, and they would be chronic disease prevention, communicable disease control, and environmental health protection. And as I said earlier, a good amount of time was spent selecting the measures to be included in the study, and there were selection criteria to aid with that selection. And this is a shortened list, but they included the domain, whether the measure was in one of the domains, relevance, did the local health department have authority to implement the activity, the expected health impact, the expected variation, across local health departments of the service or activity, how easy was the data to obtain, the expected validity, and the expected reliability of the measure. So just briefly to go over the process of the measure selection. Initially, each participating PBRN submitted candidate measures, which resulted in about 322 measures. And then the next step was to rate all these measures based on the criteria that was on the previous slide. So there was a scale of 1 to 5 for each criterion, and this was done via a web-based survey. And then the ratings were scored using a Delphi process, which is just the most highly rated measures bubbled up to the top of the list. And then the next step was an in-person meeting in Denver, hosted by the Colorado PBRN. And we reviewed all the measure ratings and shortened the list to 51 measures. And then the last step was a second rating on the shortened list of 51 measures, just using the feasibility and I believe the relevance criteria. And so the final set consisted of 32 measures. And among the candidate measures selected, New Jersey submitted 136, and they were all from the LHR. And as noted earlier by Natalie, these measures, as part of the LHR development process, underwent pilot testing for reliability and validity, as well as evaluation and guidance from the steering committee. And we are proud to report that of the 32 resulting final measures, 15 of them were taken from the New Jersey LHR. 15 were of the ones we submitted. And a partial list of these measures is listed here. They include both volume measure dimensions and reach. Reach is the proportion of the target population reached by this service or activity. So in conclusion, the take-home message is that the New Jersey Local Health Report was really fundamental in serving as support for New Jersey's capability, participation in, and contribution to the MPROVE study. And that's the presentation for today, and we'd like to thank you for the opportunity, giving us the opportunity to present, and we'd be happy to answer any questions or address any comments. And there's a link here which links to additional information on the local health report, as well as a preview of the actual Excel file. So, and then our contact information. You can feel free to contact us with any questions.
Fantastic. Thank you so much to both of you, Natalie and Susan. So we are open. We've got some time for questions and comments for those who may have. It usually works best if you can use the chat box as Golzar has just done. And so Golzar has put 2 questions on the field. Can you see that, Natalie and Susan? Do you want to take a stab at answering those, or do you need us to read for you?
The first question to me was, what process was used to decide which service categories to include in the reporting system? Given that New Jersey is decentralized, what kind of participation is secured? How will the participation of local health departments be improved? So in terms of the service categories, some of the decision filters I had mentioned at the front of the presentation. So there are services and service categories that are required by law. Retail food, emergency preparedness, uh, septic, and inspections, et cetera. So what was required by law had to be in. Above and beyond those things that are required by law, when we surveyed health departments, we found that above and beyond the core public health services, they were undertaking something like 179 different services. 75% of health departments did 40 of those. So we used that as the second filter to decide what to include. And then finally, some of those other criteria that I spoke about in the presentation helped us narrow it down even further, because in the first year, we did not want this report to be something that would take days and days of data inputting. It needed to be relevant, reinforcing, and actually useful to all the parties. So if I had to say the third most important filter, that would be the third most important filter. In terms of how do we secure participation of health departments, they're required by law, by statute, in fact, to submit information to the health department on a regular basis. It doesn't necessarily need to be annual, but that time frame is set by us. Right now, we'll be collecting data on an annual basis, and then we'll revisit it after a couple of years.
Great. Other questions for Natalie and Susan? And I see we got some other questions teed up. Maybe while we're waiting, one question I had. I know that a number of indicators you're capturing data on a monthly basis. Have you thought much about how you're going to use those data on the more granular time frames, either from an analysis standpoint or from a improvement standpoint? Some of this kind of data makes me think about perhaps using time series data, from kind of a quality improvement standpoint, run charts and other kinds of things. But any thoughts you may have about how you plan to use some of that more granular time trend data?
Yeah, that's a great question. So in year one, so as we consulted with the health departments, their concern was that someone was going to be monitoring their day-to-day input or their monthly data and then judging on the basis of that incomplete data entry. So what our commitment was that the data, the real-time data, would be opaque to us unless they chose to share it with us. This is year one. The only thing that we, the state, will see is when they push the button to submit their annual report to us. So that's year one. Later downstream, we wanted to do this in a stepwise fashion and be respectful of concerns and so on from the health departments. But later we may revisit that question and see what the comfort level is with utilizing real-time data that's of a granular nature. But not now.
Not now. Yeah, that
Not
makes
now.
sense. Very good sense. So a couple more questions are popping up. We've got one from Elaine. You guys want to take that?
Sure. Among the non-mandated questions that you referenced, did you include any questions on community planning, strategic planning, community assessment functions? An excellent question. We have not actually included those high-level strategic questions, but we must. And I'm struggling with what the highest value questions are on that level, because, for example, in New Jersey, everyone has a community health improvement plan. Everyone has a community health assessment. They've been doing this for a decade already. So I don't want to ask giveaway questions, but if you have any suggestions, Elaine, or any of our colleagues on the phone about what high-value questions we can ask around community planning, strat planning, community assessments, I would love to hear from you. And the second question from Dawn, hi Dawn, is New Jersey using a customized or off-the-shelf data platform for data collection? This is a customized report that we are building on an existing platform that we have here at the state that has been in place for about 7 years. So there's no off-the-shelf, there's nothing off-the-shelf about this. And the same is true for report generation. We have programmers that are actually building the reports now on this platform that we have existing at the state. And those are the only questions so far.
Right. Fantastic. Well, again, thank you so much, Natalie and Susan, for stepping us through the great work that's underway in New Jersey. This is very interesting work, and again, I can definitely comment firsthand. You all have been very, very important to our improved study, as Susan's presentation made clear. Obviously, many of the measures that we're working with now came right out of the work that you've done with the state reporting effort, and we're looking forward to continuing to work with our colleagues in New Jersey, as well as our other improved networks around the analysis and translation phases of these projects. So thank you so much again for the great work that you're doing there in New Jersey.
Thank you, Glenn. Thanks for the opportunity to showcase some of the work that we're doing, and we're thrilled to be a part of the Improved Network. And I would encourage the folks on the call to go to the link that Susan has posted, and you can download a copy of the Excel local health report, and feel free to steal any, all, or none of it. But that's what it's there for. So thanks again, Glenn.
Excellent.
Thank you. Thank you.
Absolutely. Wonderful. So we'll transition over to the administrative portion of our meeting agenda for today, starting just with some PBRN research updates, just on the administrative side. And speaking of Improve, we have projects, many of our Improve projects, the funding for those projects are winding down at this stage. So we do have reporting obligations that are coming up the middle of next month. So just a reminder, we've obviously been talking about this on the Improve calls as well, but a reminder about your reports that are due in the middle of next month. Again, we're glad to help you with any of that. Our team here, Lizette in particular, has become expert in the RWJ requirements for project reports, and so both your narrative report and your financial report, any assistance that you might require on that front, we're glad to provide. Lizette, do you want to say anything more specifically on that?
I just wanted to add that, of course, we understand that many of you are, just now getting to the heavy phases of your data analysis, so we totally understand that there will be products from this work that are not currently available that will be available well past this date that's on the screen. So, don't feel like, you can't be submitting products after the fact. The foundation knows that, products are something that is going to be is going to be available well past the actual dates of the end of the grant. So, we'll keep expecting those products at later dates.
Absolutely. And if you can send your reports to us, you like to see those, Lizette, a couple of, what's your timeline again for?
The reports are due on the 15th. If, I only need a day, we're asking 3 days, but it can be less than that. 1 or 2 days is plenty. I can help you depending on how much assistance you're going to need with your financial and final narrative reports. But, the more leadway you can give me, the more guidance I can give you as far as getting that back to you quickly and getting it submitted to the foundation on time.
Great. Yeah. So if you can come into us a couple of days before, we'll go through it. That way, we can catch issues and get them corrected before the final version goes into RWJ. That's always always the best path to go forward. So so keep those in mind. We also have, again, a new set of 11 PBRN studies that started up back in the middle of July. Our DAC studies, our PBRN delivery and cost studies. We're very excited about that. We've got a mix of projects all focused in on elements of measuring the cost of delivering high-value public health services, analyzing factors that are associated with variation in the cost of delivering public health services across public health settings, and understand using that variation to generate insight about the resource needs and also the value of public health delivery. We had a great meeting with representatives from all 11 of those projects here in Lexington a couple of weeks ago, right at the end of September, and I think a workshop to make progress on specifying some of the methodologies that are going to be used for cost measurement and cost estimation, and got at least the first pass of work toward standardizing some of those measures, some of those methods, so that we can hopefully be able to support some comparison across these research projects as well as within the projects, and again, to realize some synergy across the projects when it comes to methodology and data. So that, again, thanks to all of you who were part of our DAX meeting back on September 27th. And we'll keep everybody posted as those projects roll out. I think we've got our monthly DAX, set of DAX virtual meetings as well, and so we'll have our next DAX meeting at the end of this month. I think it's actually on Halloween, if I'm not mistaken. But
that is correct.
that's yeah. So wear your best costume, and we'll look forward to hearing from everybody at our October DAX meetings as well. Continue to make progress on those projects.
I'd also like to thank everybody who, all of the networks who sent in their presentations as a grant product for this DAX work. I want to thank you very much. It's awesome to have a product, within a few weeks of starting the grant. So thank you. And for those of you who have not yet sent in your presentations, I'll probably be following up with you in the next few days.
Yes, excellent point, Lizette. And that's also a great resource for those of you who are not involved in a DAX project but want to learn more about what these projects are about. We will be posting those those presentations that were presented a couple of weeks ago at our DAX workshop, and also we'll be getting those on our website so that you all can. That our larger PBRN community can get up to speed on what's happening and what we'll be learning from these projects as they roll out. And speaking of dissemination, just a reminder, some of our upcoming dissemination opportunities. First, on the Frontiers front, Frontiers obviously is our open access online journal for quickly getting out preliminary findings, new evidence, new information from PHSSR studies. Again, it's a great vehicle to use for getting kind of some of your first findings out in an accelerated time frame. We're continuing to work on this platform. We've done another round of updates and retooling of the Frontiers journal and the website here frequently over the last month, and so and we're also working on some new relationships in terms of Frontiers and its relationships with some of our mainstream traditional peer-reviewed public health journals. So we hope to have some of that finalized here very shortly and be able to announce to you some exciting new relationships and opportunities. But just keep in mind Frontiers as a great vehicle for getting out early findings and in an accelerated fashion to stakeholders in practice and policy and research who can benefit from what you're learning. I just saw the an early copy of the next issue of Frontiers, which should be rolling off the electronic presses here in another day or so, and so I think you'll find this next set of articles to be quite interesting. Also, Keeneland Conference. We've got planning underway for the Keeneland, the 2014 Keeneland Conference. It's moving right ahead. We've got a steering committee that's helping us with that work for the overall conference, and we're also starting to think specifically about the PBRN grantee meeting that we have every year in conjunction with that conference, and we'll be sharing with you as the meeting planning activities roll forward. Be sharing with you more details on that shortly. At this period of time, in the window that we're at in terms of conference planning, we would welcome your from our PBRNs in particular, your thoughts about topics, about methods, approaches, any issues that you think would be well timed and well placed for covering, specifically at our PBRN grantee meeting. We'd love to hear from you on any of those ideas that you might have over the next month or two as our planning activities roll forward. So this is just, again, a general appeal to be thinking about those issues. What kind of opportunities do you want to have for networking, for technical assistance, for general information sharing about the kinds of research that is underway within your network? Let us know any of those kind of ideas as they occur to you. Just send us an email. You can send it to our PBRN email account. It's probably the easiest thing to do. That way, it will come to our full team, and we'll be able to give it full consideration as part of our meeting planning process. And so it seems like a long way off, but spring will be here before we know it, and so please let us know your thoughts as you have them. Closer on the time frame is the APHA annual meeting. Obviously, we're just a couple weeks away from APHA, which is in Boston this year. Having spent a little bit of time with the early program, it looks like it's as usual going to be an action-packed meeting. Again, one request we'd have, if you've got a presentation scheduled to present research that is based out of research that's come out of your PBRN, please let us know. Every year we like to compile a list of PBRN-related presentations. We obviously share that with the foundation. RWJ typically likes to get staff members out to presentations that are happening around their grantees, and so we'll want to be providing them with the most complete list we can in the next week or so of PBRN-related presentations at APHA, so the public health team at RWJ can make their final plans about who's going where. So please let us know if you've got an abstract. If you could email your title, ideally your abstract as well, and session number and the scheduling information, so that we can add that to our list of PBRN-related presentations and get that off to the foundation. There's a number of things, things that, as usual, that are happening at APHA, and I know that we all face the challenge of having to figure out what we're going to do and what we're not going to do. We kind of have a tradition of having some form of a informal PBRN-related gathering at APHA, and so we're going to try to do that again this year as well. Typically, there's no way to avoid conflicts. I know that, given that there's always 4 or 5 things happening simultaneously. But Monday early evening seems to be a time frame that at least minimizes some of the conflict and some of the other activities. So we're targeting Monday at 5 o'clock for some kind of a PBRN, informal PBRN social hour gathering for those of you who will be at the meeting in Boston. So if you're going to be there, pencil in Monday at 5 o'clock to hang out with some of your PBRN friends. We haven't yet zeroed in on a location. We'll pick a location that's proximate to the action at APHA that's nearby the convention center, so that we can get there and get back relatively quickly. We'll send that location out in the next couple of days once we've nailed it down. But go ahead and pencil that in if you can, and if you don't have a conflict at 5, 5 to 6 or so. We know there's another set of social activities starting up at 6:30 on Monday, but we'll try to take advantage of being in Boston together and be able to network a little bit on that day. And of course, let us know of any other dissemination, translation activities that are going on within your network as well. We love to track that and be able to help spread the word about the good work that you're doing. As you've got presentations at other meetings or at state or regional meetings, let us know. That's the kind of thing we like to profile in newsletters. And again, obviously, if you make presentations, we love to get copies of those as well as products, particularly if they're presentations that have a permanent shelf life on a conference website. And if not, you can send those into us, and we can put them permanently on our website. That way, you can have a permanent, accessible product, another product to add to your PBRN's bibliography of projects and activities. So moving on, funding opportunities. We did want to remind folks we still are open for applications in terms of PBRN Quick Strike applications. We have received a couple. I have a couple that are in review. We'll be providing feedback on those of you who have submitted Quick Strikes in our first round very shortly. But for those of you who haven't submitted a Quick Strike application idea yet, we do still have funding slots available. So as you have an idea for a research project that is time sensitive and that is high value, likely to be able to generate valuable information for policy and practice stakeholders, likely to perhaps lead to follow-on studies and larger studies down the road. Send us your ideas in applications, and as we do have funding still available through our PBRN Quick Strike Research program. And also, as usually, if you've got ideas and want some feedback or want to brainstorm a bit with us here at the Coordinating Center, we're also glad to do that as well. So let us know. Again, probably email is the best way to do that if you want to float some ideas by us or want some feedback or brainstorming from any of our team here at the Coordinating Center. Let us know, and you can do that.
Glenn, if I could just add that the deadline for the second cycle submissions will be November 30th.
Yes, thank you, Lizette, for doing that. Yeah, we do batch reviews and submissions now. So applications that we receive between now and that date of November 30th will make it into our second wave, our second batch of reviews. And for those of you who submitted in our first wave and are not funded, we'll obviously retain your proposal, and it will be considered in the subsequent waves. And so, so keep that in mind for that date in mind for the next batch of Quick Strike reviews. But you don't have to wait for that date. You can submit it. You can send it in any time when you're ready, and we'll get it into that batch for review. Other funding opportunities. Well, again, keep an eye out on our newsletter where we feature funding opportunities that cross our desk that have relevance to PHSSR and PBRN. And we as usual profile those in the newsletter. But one in particular we thought we'd point out that came out over the last couple of weeks is a special solicitation from the NIH to support research projects examining violence and violence prevention strategies. This is an announcement that is being funded out of the special presidential order that was issued earlier this year by executive order from President Obama to support research around violence and violence prevention activities. And so that call is now out based on a Institute of Medicine report that consensus report that identified some of the priority research and information needs in this space. But we encourage those of you who have members in your PBRN who are interested in issues of the kind of public health system roles in violence prevention to take a strong look at this funding opportunity, and also the IOM report that it is based around. Take a look at that. That may be of interest to colleagues in your network. This is obviously a higher profile issue these days, and a lot of activity in the public health system, particularly at state and local levels now, around various approaches for violence prevention. So good opportunity to study these issues.
Glenn, a quick question.
Sure.
Do you happen to have an NIH grant opportunity number or something to identify this this particular opportunity, the one on violence? Or if we can get a link after the fact, that would be fine too.
Yeah, it'll be in our newsletter.
Okay, I'll just look at it.
But I'm just pulling it up on my email right now, so I do have that for you. It is. I'm clicking on it. I can give you the FOA number here in just 1 minute.
Okay.
Speaking of the newsletter, while Glenn, while you're looking for that, everybody should have received the first combined National Coordinating Center for PHSSR and PBRN newsletter. The first newsletter went out on October 10th, and it was a joint newsletter. We are using a brand new format, and I just wanted to make sure that everyone has received that. It's coming out from a different email account, so it's not the same Public Health PBRN account. And I just wanted to make sure that, it cleared everybody's spam box and people were able to receive that. If you have not received that newsletter, please email me and we'll see what we can do about, adding the correct email to your saved list. And also, we would really appreciate feedback on the newsletter as well.
Absolutely, yeah. And I think this one actually made it into that our last newsletter that went out earlier this month. But so goals are this is a program announcement. It is PA 13-363. PA 13-363.
Thank you.
Yeah, and that's the RO1. There's an RO1, an RO3, and an R21. So all three of those mechanisms that have slightly different FOA numbers, but that 13-363 will get you to the RO1 and in grants.gov, and it's a good opportunity. It's
Thanks. Thank you. I got it. Thanks.
Fantastic. So I think that's just about everything on our formal agenda, and we've got time for questions and other issues that people want to put out there for the good of the order. If there are any other announcements to make, just one closing observation I might give. I had the chance to to go out and be a part of a meeting last week organized by our colleagues at the University of Pittsburgh on some of the PHSSR-related work that's happening there, particularly on the topic of computational public health and looking at new methods for bringing some of the methods and approaches from computer science into the world of public health services and systems research. Really was I thought it was a very interesting meeting. I was really interested in some of the approaches being used. Pittsburgh has been they're supporting a lot of the work they're doing right now through an NIH Midas Award, which is a funding initiative that has been underway for about 10 years now, designed to support research around developing models of infectious disease agents and using the tools of computer science around to model spread of disease and to identify new approaches for infectious disease prevention and control. And Pitt has done some great work in kind of bringing together their public health folks, researchers and practitioners with some of their computer science folks to really spec out new collaborative ventures that take advantage of computer computation, simulation-based approaches to better understanding public health system roles and strategies. And even in this most recent initiative, have brought in some of their public health law scholars into the mix as well to model some of the effects of legal strategies for reducing infectious disease spread and control and mitigation. So just an interesting, just wanted to share that with you. It was a day-and-a-half conference that Pitt organized on that topic. I actually had encouraged them to think about doing a webinar on this topic, and there was, as a follow-up to that meeting, and there was quite a bit of enthusiasm. So we're going to be following up with them and perhaps organizing one of our quarterly webinar series around this topic, kind of computational approaches to public health services and systems research in the near future. So stay tuned on that. Other than that, I think we have worked through our agenda today, so we might be able to give you a few minutes of free time back, unless there's anything else that someone wants to put on the table for today, questions or comments. Well, hearing none, again, thanks to all of you for joining us today. Thanks again to our colleagues from New Jersey for hosting our Research in Progress segment. We look forward to seeing some of you at APHA in a couple weeks up in Boston. Again, let us know if you'll be there. Let us know if you've got presentations. And otherwise, we'll look forward to joining you back here again next month for our November meeting. Again, don't hesitate to reach out. Let us know if we can be helpful with anything as you move forward with your work in your PBRN. Thanks so much, everybody.
Thanks, Glenn. This is Susan. Thanks for the opportunity to present our material.
Absolutely. Thank you, Susan.